Okay, so we are live. We can begin.
Hello everyone. Today I'll be speaking on trendy treatments for managing common superficial fungal infections. I am Dr. Abhijit Kumar Jha. I'm assistant professor at Patna Medical College and also a practicing dermatologist in Patna. And I have been attached to many journals as a on the editorial board or as a reviewer. And today we are going to speak on a very important topic called superficial fungal infection. Now, we all know that there are three types of superficial fungal infection: systemic fungal infection and subcutaneous fungal infection. The causative agents for all these are dermatophytes, which can cause changes in the skin, hair, and nails, and candida, which affects the mucous membranes or any other parts of the body. Some superficial fungal infection can be treated or prevented with topical antifungal agents, and some require systemic treatments with oral antifungals. Now, 25% of the global population has skin mycosis, including tinea infections. Fungi from Trichophyton, Microsporum, or Epidermophyton genera. T. rubrum is the most commonly associated with tinea cruris. Other forms of dermatophytosis, depending on the site of infection, such as tinea capitis if it's the scalp, tinea corporis if it's the body, or tinea versicolor, or the pedis, or angom, or tinea incognito. Now, for knowing this, we need to know a few definitions, which is very important. The first one is dermatophytosis. This is an infection of the skin or skin derivative caused by fungi known as dermatophytes, leading to erythema, small papules, vesicles, or any ring-like morphology. They invade and multiply in keratinized tissues. This is important because keratinized tissues involvement in superficial fungal infection, this is where newer treatments are coming, and they go and attach to the keratinized tissues and they act. That is their mechanism of action. Now there's a term called as naive infection. This is the first time an infection which happens to a person, or when a person comes to us and he's not taking any treatment for that particular disease. The other three terms, which is very important, as chronic dermatophytosis, recurrent, and relapse. Now we need to differentiate between chronic, recurrent, and relapse. Now, the chronic infection is when a person who has already suffered from the disease for more than 6 months to 1 year, with or without recurrence, in spite of being adequately treated, is called as chronic dermatophytosis. Now, recurrent dermatophytosis is when there is reoccurrence of the disease within few weeks. Within few weeks means less than 6 weeks after the completion of treatment. And relapse, when a person has been cured, there is a disease-free interval of 6 to 8 weeks. That is called as relapse. And then there are new terms such as trichophyton rubrum syndrome. In this, there are four sites which is actually involved: the feet, hands, nails, or any of these except for the groin. We have a positive microscopic analysis of KOH, of skin scraping, and identification of T. rubrum by culture. Now, body surface area, we all know one size of the palm we take as 1%, and if it's less than 3%, it is actually mild. If it's 3 to 10%, it is moderate, and more than 10% is severe. Now, the clinical appearance of lesion with a history of prior treatment, along with knowledge of pharmacological properties of antifungal agents, will help guide the choice of therapy. Further to this, experts have identified the skin area involved, such as dry sebum ridge and the age of patients, as additional factors influencing the choice of treatment. Now, before we come into laboratory tests, we need to know three things. The first one is, what is mycological cure? The second one is, what is clinical cure? And the third one is, what is complete cure? Now, for knowing if the patient has a full mycological cure, we need to take into consideration two things: when there is negative microscopic analysis of KOH and there is negative fungal culture. This is when the person is said to have complete mycological cure. Clinical cure is, suppose we are treating a patient with onychomycosis, and when the nails is completely cured, looks completely cured, and the nail has come as normal as it was in previous time, then we can call that as clinical cure. Now, complete cure is when we take into account of these two. The first is the mycological cure, and the second one is as clinical cure. So that will be considered as complete cure. So our main target when we treat a patient should be complete cure. That is mycological cure plus clinical cure. Now, for better yield of results, the age of the lesion should be the most prolific site for skin scraping. So whenever we are going to take our skin scrapings, we need to know that we take it from the edge of the lesion. This is a very, very important take home message. The second one is they recommend the use of culture in special situations such as recalcitrant or multi-site tinea cases. Now, topical and systemic antifungal agents for treatment. And I'll also deal with a few new treatments which is upcoming for onychomycosis and that also of superficial fungal infections. Now, topical antifungals can be divided into polyenes, azoles, and allylamine or benzylamines. Now, oral treatment, we all know and we are well known to prescribe itraconazole, terbinafine, fluconazole, griseofulvine. Now, the trick of the trade is how often and when are we going to use these kind of drug for treating superficial fungal infection. Now, the newer antifungal agents are also coming to the market. Laser therapies have been used for onychomycosis, but it should not be used as a first line treatment because it does not give us a permanent cure. Now, there are selected properties of antifungal agents such as amphotericin B. It acts on Candida species or Aspergillus species. I'm not going to details of these slides because for our practicing dermatologists, we need to know when and where to use this kind of agents. Now, terbinafine also acts on Candida and dermatophytes. Ketoconazole or under the imidazoles, they also act on Candida, uh, H. capsulatum, and others. Meconazole also acts on Candida. Now, triazoles are fluconazole and itraconazole. Fluconazole, at least 2 decades back, was definitely the treatment choice for tinea, but these days, even itraconazole is tough to treat, is a tough molecule, and it is tough to treat superficial fungal infections. Now, the polyenes are not discussed here because this group of compounds are not effective in the treatment of dermatophyte infections. Alkalamines and azoles we are going to discuss. Most dermatophytic skin infections in their early stage are responsive to topical therapies. Examples are interdigital tinea, tinea curis. But once there is involvement in nails or hair of hair, topical therapy is rarely adequate. Now, reasons for using antifungal agents are onychomycosis, tinea capitis, extensive tinea, failed topical treatment, immunocompromised patients. We also see a lot of tinea incognito patients in our setup where patient come to us with application of topical corticosteroids given as an OTC, and this also has led to resistance these days. Now, these are systemic treatment for dermatophyte infections, but there is no say that okay, if it's tinea pedis, we're going to use it for 2 weeks or 1 week. I think in our practice we are going to use for a longer time, and in general, in tinea corporis or cruris, I think most of us uh, take at least 3 months to treat these kind of infections. Now, onychomycosis due to dermatophytes like terbinafine, itraconazole, fluconazole, they can be used. Now, tinea capitis, most likely we use terbinafine or griseofulvine. Now, this take-home message here is we use terbinafine in children above 2 years of age. Below 2 years of age, we're going to use fluconazole, and above 2 years of age, we are going to use terbinafine. Now, this is an important part because nowadays even syrup itraconazole has come into the market. But when you talk about this, it is generally used for oropharyngeal candidiasis mainly, and it should not be used left and right. And below 2 years, please do not use itraconazole. I don't prefer actually. Now, better why itraconazole is a better triazole? It has activity against dermatophytes, yeast, molds. It is also having fungistatic properties. It accumulates in the stratum corneum and nail material, and it has very high affinity to keratin. In my previous slide, I told that the superficial fungal infections actually go to keratin, get deposited there. So itraconazole is a molecule which goes there, attaches to keratin, and therefore it is primarily a fungistatic activity. Later on, it acts by killing those. It also belongs to modern, highly effective systemic antifungals with a favorable risk-benefit ratio. Now, itraconazole has pellets. So when we use itraconazole, when you're going to break the itraconazole or you're going to open the capsule, you're going to find pellets. And the small pellets, depending on which brand we are using, that is an important factor too. Now, itraconazole is a weak base, so it has to have a low pH to get better results. So gastric acidity is actually an important part, and you should immediately take itraconazole after a full meal. Acidic beverages such as cola also enhance the uptake. Now, the extensive protein binding of itraconazole ensures that the concentration of the site of infection remains higher than the corresponding plasma concentration for several days. Now, itraconazole is lipophilic and it is highly bound to plasma proteins. I'll skip this part. Now, these are few important things. When Cobbenberg, when he gave 200 milligram of itraconazole for 7 days, the plasma steady state was reached within 4 days after the start of therapy. Now, the steady state plasma levels ranged from around 500 to 650 nanogram per ml. I'm not going to tell 498 to 460 what is it is an approximate value. Nitroconazole levels in the sebum became measurable after 4 days. Now, this is important. When we're using itraconazole, its level in the sebum is measurable after 4 days. But when it is the measurable part, but when you detect itraconazole in the serum, it is only 24 after 24 hours. So we need to know exactly that wherever the site of sebum production is more, such as the beard, the effect of itraconazole there is actually better. Now, itraconazole becomes detectable in sweat 24 hours only after the first intake of medications. Now, similar results of itraconazole level were seen in stratum corneum of the back due to even distribution of sebum and sweat gland. 1 week after the end of therapy, the sebum still contained therapeutic levels of itraconazole, but sebum levels were no longer detectable weeks after the end of therapy. Now, there are few adverse effects of this drug. Most likely nausea, headache, abdominal epigastric pain, and few are like GI and epigastric pain are actually exaggerated. But in our daily practice, we also see patients complain of hair fall. Then we also see patient complaining of constipation after taking itraconazole. And who have a previous history of piles, I think we should decrease the dose of itraconazole. What I have found in my practice that there are a lot of patients which come and complain of hair fall, constipation, and few fixed drug eruptions were also noted in our daily practice. Now, compared to terbinafine, this is a broad antifungal spectrum and it has better effectiveness against onychomycosis. The important therapy option for treatment of dermatophyte infection of glabrous skin like Tinea pedis, Mannum, Corporis, and Tinea cruris. Now, we already spoke this that it's highly bound to plasma proteins, it's lipophilic, it accumulates in the tissues to levels 2 to 20 times higher than serum concentration. It has low affinity for mammalian P450 enzymes. Its level in the stratum corneum exceed the plasma levels and may persist in skin and toenails for 4 weeks and 9 to 12 months respectively. Now, there are few drug interactions such as quinidine, terfenadine, estimazole, cisapride, lovastatin, OCPs. So generally, we should not use itraconazole along with these kind of medications. So it's very important for us to ask patients whether they are taking OCPs or whether they are taking these kind of drugs. There is a long list of drugs actually. So it is also not to be used along with steroids like dexamethasone, and so we should be very cautious when you actually give this. So some of us may be using systemic steroids, but I think we should not use systemic steroids. Like a patient comes to us with allergic contact dermatitis and tinea, we use systemic steroids along with itraconazole. I think that practice has to be stopped and we should not use it. Once the tinea part subsides, I think we can put the patient on topical treatment for allergic contact dermatitis and antihistaminics. Now, a few important points. In elderly patients, if we need to use this kind of treatment, first and foremost, topical therapy should always be favored in elderly patients. Secondly, if the patient is healthy, if he is an elderly but a healthy individual with no comorbidities, we can use the same dose we use in young adults. Otherwise, oral terbinafine should be preferred in elderly patients. Now, for pediatric age group, we know that terbinafine and fluconazole should be the treatment of choice. And terbinafine is to be recommended only after 2 years of age. Now, topical antifungals for pregnancy. This is a controversial topic, but in pregnancy, most of us prefer topical antifungals, and I think most of our dermatologists would agree that we use mostly topical agents for treating fungal infection in pregnancy. Secondly, terbinafine is a pregnancy category B drug. However, its data on its use is not well reported, so we need to be cautious here also. Now, regarding itraconazole, there is effective contraception for 2 months, should be there, and it should always be suggested to patients. This slides have been taken from an expert opinion by Dr. Mullidhar and Dr. Dogra sir. They have written an excellent article, so I have just took this from their article. Now, there are newer therapies for onychomycosis. Now, the first one is cyclopirox, which is an 8% nail lacquer. The second one is efinaconazole, 10%, and tavaborole, 5%. So these two are important drugs. We need to know this too: the efinaconazole 10% solution and the tavaborole 5% solution. And these are new therapies approved by the FDA. And I hope soon we get these drugs in India. The second, which is being tried these days, are photodynamic therapy. Now, this photodynamic therapy is something where a photosensitizing agent is applied, and when that is applied, visible light like methylene blue around 625 nanometer is used, and when that is used, it generates free radicals, and it damages. It also expresses the free radicals and reactive oxygen species that damages the cells from of fungus. So this is actually a trendy treatment, and this may be coming up in a few days from now. Now there's a plasma therapy. It's not the plasma therapy which we think. This is a plasma therapy where the pulses are created in air and there is an electric current. So there are two kind of plasma therapy: the thermal plasma therapy and the non-thermal plasma therapy. Now the non-thermal plasma therapy is preferred as thermal plasma therapy causes a loss of lot of heat and it can cause tissue damage. So non-plasma therapy is being used. Now for onychomycosis also, few of us, they drill holes in the nail plate and they put in terbinafine spray, and that is also an alternative which many of dermatologists use abroad. So we generally tend to stick to cyclopyroxylamine and uh, itraconazole. Now there is also a few good terms, which is the first one is a booster therapy. Now, what do you mean by booster treatment? So this treatment, this was discussed in JAD in a paper in 2018. So booster therapy is when a patient is given itraconazole for 6 to 9 months before. When a patient was given 6 to 9 months before itraconazole, and after that we give a 4-week treatment of the same itraconazole. It is called as booster treatment. This is because itraconazole binds to keratin and they stay there for some time. So for 6 to 9 months if we use, or for 3 months if we use itraconazole, it still remains in the keratin tissues or somewhere. So there is some effect of itraconazole. Just to make that live, we again use itraconazole after 6 to 9 months of initiation of antifungal medication. We can use that as terbinafine or itraconazole, that doesn't matter. Now, there are few clinical articles like itraconazole and terbinafine is perspective from preference to patient, and there are few more like some small dose itraconazole pulse therapy in treatment of onychomycosis. Now, effect of terbinafine itraconazole in different doses. Now, reason of failure for management is antifungal drug resistance, patient compliance, which is important. Superficial fungal infection are a significant source of morbidity in affected patient due to cosmetic appearance, discomfort, pruritus, and hair loss. Recognizing this condition will help to choose proper therapeutic intervention at an early stage. Now, the combination of topical and the systemic therapy is important. Now, secondly, when we are going to use topical treatment in nail infection, when the patient has acquired the infection for the first time or has not been treated, we should try topical agents first, and then we should go on with systemic antifungal treatment. Thank you.
Yes, sir. We can move on to the Q&A.
Yes, we should move on. Yes. Do we need to go to?
So you don't have to share, just view it.
Okay. I think I've covered most of the questions which have been asked. Uh, I think we take questions from the audience.
Yes, sir. Can you take them once again, sir, as a revision for the audience?
How to get a cure from fungal infection area when skin is turned red? This is a question by Chetanan, Dr. Chetanan, and from Bangalore. Hello, Dr. Chetanan. Hi. I think we need to first use an anti-inflammatory agent, and I think we should use a topical agent first, along with pulse therapy of itraconazole, and we can also add on antifungal powder if required. The second one is what is safe antifungal medication that is effective for dermatophyte infection. I've covered this, Dr. Radha, in my lectures. Like in pregnancy, we go and we get ourselves accustomed to topical agents mainly. Otherwise, we have to see the risk-benefit ratio, and terbinafine is a category B drug, and you would be the best person when you're going to prescribe that to a pregnant female who comes to you. And generally, I don't prefer prescribing an antifungal, a systemic antifungal, mainly if it's the for the first 3 months, because that is the organogenesis when it's happening for the child or for the kid. Uh, what should we advise on fungal infection pregnant women or females in reproductive age group? I already told you itraconazole. If you prescribe, we need to tell that okay, itraconazole, 2 months contraception is required, and that should be there. Uh, in case of recurrent infection or long-standing fungal, any specific lab test we should do? Yes, we should go on with fungal cultures because it is not available everywhere. And for we should always try first potassium hydroxide microscopic analysis, and then we should go for fungal culture. In case we have to recommend in pregnancy, what topicals and terbinafine dose. Generally, ketoconazole, meconazole is actually kind of safe. But to be very honest, topical drugs generally do not penetrate, and you can use topical agents of your choice. And terbinafine can also be used. Okay, now terbinafine, can it be used in the second trimester? For how long? It can be used for 4 weeks or for 2 weeks first, if it's a very widespread tinea. Otherwise, I would always say that we should use topical antifungal agents. Uh, I think we are done with the questions. Do
Yes,
we
sir.
have any more questions?
Yes, sir. We are just instructed to wait a few minutes for any more questions that might come in. The
Sure, sure.
audience are requested to just post any questions that they might have on the box that is provided on the site. Please note you can send multiple questions, as many as you want. Sir, in the meanwhile, would you like to discuss about some interesting cases that you might have come across?
Yes, there were a few cases. There's a patient of mine who had come to me with extensive annual lesions, and we did not take proper history at that time. Maybe that was our fault. It was a busy OPD. So we prescribed antihistaminics and told him to come back. And we thought of porokeratosis, rosea, and others. But after the next visit, after 2 weeks, when he comes to us, things did not get better. So we asked him whether he had used some steroids, and he said, "Yes, sir, I had used some steroids." And so we should always take history of prior topical treatment, what the patient had actually taken. So steroid application of topical steroids actually changes the picture totally. So tinea infection would look something very rare, maybe like erythema annular centrifugum and stuffs like that. So we need to know exactly the proper history. We need to have a liver function test done, because when a patient comes to us, maybe he had already had itraconazole from somewhere, or maybe from the medicine shop directly, and his liver function tests maybe didn't. So whenever we need to use itraconazole, we make sure that if it's more than 30 days, we take an LFT done. But in our daily practice, we hardly see that there are a lot of liver function test enzymes like SGOT, SGPT, which has been elevated. So this is important. The second part is when to use terbinafine. Now, terbinafine is actually a safer drug, but due to fear of resistance, we generally don't use. But I would also suggest that we should use terbinafine. Yes. Is there any difference in the application of 8% cycloperoxy nail lacquer as compared to amorphine nail lacquer, and which one is better? See that depends. Once is a daily application, and once is a weekly application. So, Dr. P. Sethi, I think in our practice, even a daily lacquer would be good because patient thinks that there is something which is to be applied, and then they apply it. Now, so what is the medication for pediatric dermatophytosis? Now, the medication for pediatric dermatophytosis depends on the age. I think Dr. Vinod, I think Dr. Chandan has asked this. Hello, Dr. Chandan, and it's a good question. Medications mainly we start with topical, but these days we also know that topical antifungals are not only topical antifungals should be used first, but that if that does not respond, we go to itraconazole, and when itraconazole doesn't respond, we go to griseofulvin. But griseofulvin has more adverse effects, so we should stick to terbinafine. And if it's the patient, if the pediatric age group is a bit higher on the high side, like 10 years, 12 years, we can use itraconazole too. Uh, combination of two antifungals help. Yes, it does help, and it definitely helps. Antifungal agents definitely help us because when you use a topical and a systemic antifungal, like in tinea pedis, there are maceration, and the maceration of skin can lead to the entry of organism. So this is where we use uh, topical therapy as well as systemic antifungal therapy. And secondly, we also use keratolytic agents except on intertriginous areas of face and face. Now, intertriginous areas and face, we should not use salicylic acid 3 to 6%, but keratolytic agents can be used because they can shed in some scales, and then they can do that. See, I think to know this, which are two antifungal combination helps, and if yes, which is best? Uh, in my opinion, there was an expert consensus on dermatophytosis, and they came to a conclusion when itraconazole and cycloperoxoriamine, if we use in adults, they give us actually good results, and they give us very good results. Now, is itraconazole or not better than combination? Acha. In regard to MIC, management of fungi, which is generally considered the cutoff between susceptible and resistant. This I actually don't exactly remember the exact cutoff point, but I think it is a good question, and I'll come back to it maybe in the next session because this I forgot exactly what was the MIC measurements. But this is a very very good question because we need to know when the patient is susceptible to itraconazole or resistant. But in our setup, I think itraconazole works in most cases. If not, the itraconazole has not been used in a proper way. I use itraconazole on better than combination long-standing. Yes, itraconazole is better because it you cannot use a lot of systemic antifungals together because that can cause even liver function derangements. What is the duration of itraconazole in chronic dermatophytosis infection? The duration of chronic itraconazole in our practice, generally we use it for 3 months, and we suppose chronic when a patient is having chronic dermatophytosis, we need to have a fungal culture done, and if fungal culture is done, then we can understand which organism and which agent is actually susceptible, and we can use it for a period of 3 to 4 months. I think after 4 months, maybe we need to change our treatment. If it's suppose if you're going with terbinafine, then we go to itraconazole. If it's itraconazole, we go on to griseofulvin, and there are few micronized griseofulvin also available in the market which we can use. This is a question by Dr. Frenny from Hubli.
Yes, sir. You were just finishing up on your case that you were mentioning, right? When you started with the question.
Yes, yes. So we need to actually know, because when patient comes to us, we need to ask proper history if the patient has already been taking itraconazole. Because once we give itraconazole to the patient, now we have not done his liver function test, and we actually don't know his exact SGOT, SGPT analysis, and then we might damage the liver more. So we need to know first, when a patient comes to us with 3 or 4 months treatment of itraconazole, we need to know which brand has been he using, and maybe we need to change that brand, because that brand maybe maybe not that effective as compared to the innovator brands. So we need to cut down on few things. We need to also tell them that you need to stay cool, by in the sense means if you sweat a lot, you need to work in a colder environment. We need to make your clothes ironed properly when you're using it or when you're applying that. And we need you need to not to share towels or bed linens. So these are few important parts which you need to tell your patients. uh, I think is there, yes. Antifungals you advise in cardiac patients. Okay, cardiac patients, actually itraconazole we need to avoid, and if possible, we need to give patients a topical therapy. And suppose terbinafine can be tried in such patients. In I prefer in immunocompromised patients with widespread tinea. Generally, I prefer itraconazole, but to be on a safer side, terbinafine is a good choice, Dr. Gitanjali. In the meanwhile, we need to also know how to differentiate onychomycosis from other differential diagnosis. Now, nail clipping is also important. Many of us don't practice nail clipping, but we should do nail clippings also. Now, the second part is when we use topical lacquers, so we need to educate the patient exactly. And I would be happy when efniconazole and tavabarol approach for onychomycosis. It will be a good thing for us. And photodynamic therapy or non-thermal plasma therapy are also a good option. Okay. We had a patient with multiple metabolic disorders, deranged lipid profile. How about advising best mode of treatment? This is from Dr. Rajender, Mumbai, I guess. Yes. Yes. Multiple metabolic disorders. See, my preferable, I would prefer topical antifungals along with maybe terbinafine, because itraconazole would have an effect on heart, and it also may be linked with congestive heart failure and stuffs like that. So we can use terbinafine, or we can use fluconazole. Onychomycosis in elderly patients with liver disease. Okay, this is a catchy question. So onychomycosis, generally you can give a weekly therapy of fluconazole, and I think that would be a safer way. And we need to have liver function. We can add on silimarine or something, which is a liver tonic, or maybe we need to know if the serum bilirubin is also high. So we can add ursodeoxycholic acid along with terbinafine. An elderly patient, terbinafine will be the preferred choice. Sheetal. I think we had a lot of questions today, and we'll be waiting for a few more questions, maybe.
Yes, sir. We just wait a few more for the questions.
Yeah, sure. We generally advise fungal culture, Dr. Prashant. We advise fungal culture only when we have a case of relapse. So this is when we actually ask for fungal culture, because it's not done in all setup. Although we work in a medical college, so it is easy for us, and we also need to wait for quite a long time. So I think fungal culture will be advised in those cases only, because in a patient, when a patient comes to us, we generally don't tell them to go for fungal culture. But yes, microscopic analysis of KOH would be a good choice when we see normal patients. And to be very honest, I think itraconazole is being sold left and right, and people are using it left and right from the over-the-counter medication. I think this practice should be stopped, and I think I would prefer that patients should be given dermatologist only on dermatologist prescription or any doctor's prescription per se, because people go to the medicine shop and they ask itraconazole hai, aap de dijiye mujhe. I think that trend should stop in India. Without prescription, I think medicines should not be prescribed. this is the most important thing which needs to be done. And I think our association can also take a lead on this part. Is the indoor aesthetic process like chemicals by superficial image? Yes. Now, see, when some people have used a few things like maybe glycolic acid or salicylic acid. Like salicylic acid, yes, that could be a good option. We know it's also keratolytic agent, but as I said, 3 to 6% of keratolytic agents has been used in tinea, except on the intertriginous areas and face. So yes, we can try salicylic acid kind of peel, but I would not prefer this because aesthetic procedures, I think that should be limited to our cosmetology and it should not jump into superficial fungal infection. Mm, yes, some medications do, Dr. Mamta, yes, some medications do exacerbate fungal infections like systemic steroids. It does increase the chances of having fungal infection. And in our practice also, we have seen we had given some tapering course of systemic steroids like methylprednisolone and on that part. And then after that, the patient developed tinea, and we had to give him a course of at least two months course of itraconazole. So that needs to be avoided. We still wait for some.
Yes, sir. Sir, a few more questions have come in.
Yeah. Yes, nystatin you can use for athlete food. That's actually good. We can. I would also suggest that we can add in a bit of keratolytic agents also because maceration is there. So salicylic 3% would also be a good option along with this nystatin. And combination of two systemic antifungal play any role in if yes, which is best combination? I never prefer combination of two systemic fungal two systemic antifungals, Dr. Vinod. And I would always prefer only one mode of treatment. Some people use fluconazole and terbinafine together. Maybe, but that's all right. But I think either we use fluconazole, itraconazole, or terbinafine. We don't use it in combination. But yes, we see some quacks using terbinafine along with itraconazole or some other people. I think Dr. Vinod, you'll be the best person to understand that two systemic antifungals generally should be avoided. But if in cases you want to use, I think fluconazole terbinafine would be a better option, and fluconazole itraconazole would not be a good option, I guess. I think we are done, Dr. Harish. Okay. Now, malassezia folliculitis, we generally use ketoconazole, and ketoconazole shampoos also we use. So when we use ketoconazole shampoos, also together when it has been applied for malassezia folliculitis. So I generally prefer a ketoconazole shampoo along with a ketoconazole or a ketoconazole lotion along with antibiotics also.
So we just wait 5 more minutes in case there's no new questions. We can end the session then with
Yes.
your take-home message. Okay.
Okay, sure. Betadine generally we don't use, but Dr. Hara, I think if it works, I think it would be a better way because superficial superadded bacterial infection can be prevented by using this, and this is a nice idea. I think we can use betadine in fungal infection and toenails generally, or we use an antibiotic together along with this in a chronic paronychia kind of lesion. Now, Dr. Harish, I think yes, malassezia folliculitis was a good question because this can imitate acne form eruptions. So we really need to know whether this malassezia folliculitis is actually acne form eruption or it is malassezia folliculitis. I think Harish, Dr. Harish, you that was a very good question. Now for medication, malassezia folliculitis is like you can use other antifungals also like itraconazole or fluconazole. But ketoconazole lotion, I've seen that in practice it does work. There was a paper in JAD, I think they had also mentioned this malassezia folliculitis treatment where they use ketoconazole. This is how we differentiate also with acneiform eruptions. We use ketoconazole shampoo, and in case of acne formation, it's not going to get better. But yes, malassezia folliculitis does get better. So this is also kind of way to diagnose these kind of or differentiate these two infections. I think we had very good number of questions for this webinar, and they were
Yes,
all good.
doctor.
They
We
were all
can just
important ones.
yeah, we can just take the take-home message now.
Yeah, I think take-home message is in elderly patients, terbinafine is the treatment of choice. Secondly, in pediatric patients below 2 years, try and use fluconazole. Above 2 years, try and use terbinafine. In pregnancy, terbinafine is a category B drug, so we can use that, weighing the benefit and risk ratio. I think I would always prefer to topical agency irrespective. If it's a very widespread tinea, I would go for terbinafine. These three are the most important take-home messages. Few ones are efinaconazole, tavabarol, phototherapy, non-thermal plasma. These are trending treatments for onychomycosis, and I think this is all what I can say. And I think if I had lack of few, I think I missed out a question on MIC, and I think that we need to work up because MIC is also an important part, and microbiologists actually deal with such things. But we should do a study where we see MIC between susceptible and resistant patients. Thank you. I think we end the session.